Welcome, everybody. This is Doug McCall from the International School Health Network. Pleased to be welcoming participants to this webinar, which is looking at school health and development in low-resource countries. I'm pleased to be introducing Sung Lee, who is the Senior Director of the School Health and Nutrition Program at Save the Children. I'm hoping everybody can see the slides, and what we normally do in these webinars is we ask the presenter to go through her or his remarks, and then as you're listening, please type in any questions or comments in the chat box, and I'll come back and then read them out, and then we can go into the discussion phase. Sung, I'm going to advance the slides at your request. Just say advance, and I'll be able to do that. So I'm hoping everybody can see the screen, and we'll begin. Just a brief introduction to this series of webinars. It's really sharing the work of Fresh Partners, and you can see on the screen that we've had five sessions. They're all related to a conference that ended up being a virtual conference, a comparative education conference that was to be held in Miami. And so we had planned to do a series of webinars leading into a panel presentation. So if you go to that web page at the top of the screen, you'll be able to find the recordings from all of these sessions at the end of, the last one is tomorrow. And the panel presentation, which brought them all together, is in the middle, is on April 23rd. And so if you look on that page, you'll be able to see them. These are some of the reports and papers that have been developed by Fresh Partners. And again, if you look through the Fresh website, you'll be able to see them online. So this is my pleasure to introduce the series of webinars that have been led by Save the Children. They're really an excellent series that started in 2016 with Save the Children running them, and then they continue through the Fresh Partnership. Every month, about the 15th of the month, webinar is held that focuses on low-resource countries, and you can see that we've had over 50 different sessions, and there's lots of recordings and resources that have been led by this session. So I'm really pleased to be introducing Sung and to ask her to take over. And Sung, I'll just advance as you need them.
Great. Thank you very much. Thanks, Doug, and for organizing this. So I've been working on school health and nutrition for about 20-some years, in the past 16 years with Save Children. And then, as Doug mentioned, the past 4 or 5 years, we've been hosting these webinars. And I will say personally that I have not managed to go through all of them. I've attended most of them, but not been able to actually attend all of them. And I definitely have not done what Doug has done. Apparently spent Easter weekend going back and listening to the webinars, and he says they were as good as Netflix shows. I had a hard time believing that, but I'm so glad that it's making some people happy to have these webinars. The webinars were started because there was so much experiences and organizations and partners implementing school health and nutrition activities, with also academics and partners and universities being research partners. And so there was a lot of experiences and knowledge being developing and growing, and we wanted to make sure there was a chance to share it out as much as possible. So I think next slide. Oh, okay. Yeah, so this is, I just wanted to go, sorry about this, I don't have the deck ahead of me, but just to go back to say the Fresh framework, the school health and nutrition framework, I wanted to kind of go back and look at that really quickly. So all these experiences from different organizations was really interesting, because regardless of the actual frame, detailed program design, within the Fresh framework, you can find the pieces. So I just wanted to kind of go back and remind us what the Fresh framework is, what it means, and what it stands for. So it's focusing resources on effective school health, and it's based on 4 pillars: policy, school environment, health education, and health services, and which are supported by what we call cross-cutting strategies, or I like to call them the foundation. And it's effective partnership between the critical ministries. in most cases, it will be Ministry of Education and Health, but occasionally there are other parts that come in, and it's really looking at the right partnership at that global structural level. And it can be at national, it can be international, national, regional, local, but critical to have that link. And then the second was the community and family, making sure that parents are involved. And then the third is the actual child participation. So I wanted to go over that because this was a framework that was put together 20 plus years ago. And I think the idea is that these are some critical pieces. And over the 20 years I've worked on school health and nutrition, I feel like these are the right pieces. Things may change for effective programming because context is so important. And that's what we're talking about, low resource countries, because there's so much more we can do with a lot of resources, but with the low resources, we have to look at these pieces and understand which pieces are critical to have effective programming. But again, this is a very simple framework, but actually it seems to work. And I wanted to kind of always refer back to the framework, looking at things we've learned in the past 20 some years. Next slide. So again, just wanted to share, this is within Save the Children internally, but you can see I started with Save in 2005, and we were gathering the program managers at regional meetings, and then we went to global meetings where, again, the context is different, but we were able to share and learn from each other. And I think the webinar really serves that purpose to understand there's a great framework, there's a lot of research being done, but the actual learning does happen when you're implementing and trying to figure out how these pieces work to be most effective. So next slide. So I just put this together last night, and I'm not as scientific and put together, like I didn't do a PhD, whatever, for different pieces, but I thought these are some of the key things that came out. And again, the prioritization is critical in a low resource setting. If the resources was not a constraint, there's so much more we could do and want to do. But I did want to highlight that piece. And then the rest of the webinar presentation, I will be using some examples and showing how choices had to be made. And that may or may not lead to really effective programming. I think there's a desire to do more, but effective programming also means being able to do the activities, and prioritization is critical. And then roles and responsibilities, again, that seems to be really critical. And when you start breaking down all the roles and responsibility, coordination between these different roles and responsibilities become paramount. You end up having so many different people and partners involved. Without the proper level of coordination, there's a lot of duplication. And going back to the scale and sustainability, there's a lot. Again, doing the small scale, we can do a lot, but that requires a lot of money. And once you try to scale it up, the cost factor makes it so that it's not so sustainable. Adaptability, again, looking at that. And then evidence, because there's a lot of things, and I will say this as a global thing, not just school health and nutrition. There's a lot of things we do, we feel like it's the right thing to do, but sometimes without the evidence, we may not be being cost effective. We may be doing things that's good to do, but we may not have the level of effectiveness. So these are some thoughts I had, and I will be speaking about each of the examples using some of these pieces. Next slide. So prioritization is critical when you look at these health conditions that we could be dealing with. If you were to deal with all of these, the children would be in school every day and taking all kinds of lessons and health issues. So I wanted to kind of flash this as an effort to reduce some of the health issues that school-age children might be dealing with. And SAVE has tried to lump them into these groups to make it easier, but even then you're still with 13, 15 more issues, and they just can't do all of them. So again, just to highlight all the issues that we could be addressing. Next. So this is a classic one, and I think I've used this slide many times. I do use this slide as a great example of the changing in roles and responsibilities, scaling up, adaptability, and sorry, I'm just getting a lot of echoes here. Uh, Looking at the scalableness and the changing partnerships. So this is where deworming is something that we started about 20 some years ago. And when we started, the roles and responsibilities were very different. We wanted to start this as a pilot, so we actually bought the drugs, went in and worked with the teachers directly and trained them and helped them deliver the drugs to the children directly and kept track. So it's a small model and that's a lot of hands-on ability. And that alone describes the different roles and responsibilities. As an NGO, we were working to start a new program, so we were very hands-on. And because the teachers were available and health workers were not, we actually had teachers giving out the drugs. And we did get permission from the ministry staff so that we could think about long-term scaling up. But again, there was minimal involvement. That was 20 some years ago. And that was at that point, we were able to actually do this because the drug protocol had changed and we were allowed to use the drugs using mass distribution. Again, that allowed us to be giving out pills without changing the ability, the capacity of the teachers much. We were just asking them to deliver the drugs as opposed to doing any diagnostics. Things have changed and evolved to the point where, as an NGO now, our role is none of those above. We are actually trying to be hands-off and leaving the Ministry of Education and Ministry of Health to work out the details to be able to deliver the drugs directly. And this is, again, the context is very different. In some countries, teachers are still tasked to deliver. But in many countries, the Ministry of Health is saying, no, we actually want the health staff to be there. So they come to the schools using school platform, but having the health workers actually do the delivery. And it is scaled up to the point where, again, as an NGO, we don't do much. We actually, what we want to be doing is checking to see that the schools where we are interacting, that the children are getting the drugs. So again, the change in roles and responsibility and having a clear understanding. A good example of things that, in the beginning that wasn't done correctly, for example, is that the teachers, the Ministry of Health, we were very excited about this, but there wasn't as much communication with the community members and the parents. And there are some examples from the very beginning where the parents were concerned about teachers delivering health interventions, and they actually withdrew the students from the schools. So this is an example where a lot of lessons learned, and people forget that parents are the actual guardians of students and children, and they need to be involved and understand what's going on. So the role of parents are critical and having them be involved. Teachers, instead of just giving them the role of delivering it, their role is critical and that they need to understand why they're doing this, how this affects their outcome. It's not about health outcomes only, it's actually about the education outcome, which is critical. And teachers need to actually add health education pieces. So now looking at the different pieces. It's health service delivery, but we need to actually have the health service education that the children are learning about good hygiene so they don't get reinfected. So we're not always deworming children. And then the school environment to make sure that there is a clean sanitation and hand washing facility for children to use, so that element's there. And then the policy, having a policy that says students will be dewormed through the school systems every 6 months or every year, depending on the prevalence. So the four key pieces, and they're still there. And I was challenged just a little bit. So I think there's a lot of learning from just this one intervention. We went in with what was relatively considered a low cost item. We were just delivering a deworming tablet. But actually that wasn't correct. We needed to do deworming. We needed to train the teachers to understand. We need to communicate to the parents to understand what's going on. We need to make sure that the messaging was done well so that the kids were taking the pills and then washing their hands. And then we have to actually work and make sure that the school environment had the right environment for the children to practice good hygiene. So those are different pieces, and we had to make sure we had those pieces in the activities and make sure that the roles and responsibilities were laid out. And then the cost factor to see what can we do to make sure this was actually doable at a national scale. What's interesting for this one is that we were able to get the private sector involved, and they are donating the pills. So which was one of the cost factors that the scaling up was a concern, but with the involvement of the private sector, that's a cost factor that was reduced. But we still had the need for the other pieces to make sure that it was done properly as an effective programming. Again, this is an example of how things do change, looking at the different roles and responsibilities and effectiveness. I'm going to stop talking about this one. Next slide. And the next few slides I'm going to just go through really quickly. So that was an example with deworming. And then malaria in schools was interesting. We had to make a change in our treatment of malaria because malaria prevention was doing, for under 5 was being done so well. Cases of malaria in school education was increasing, and it was more noticeable in school systems. So in 2000 in Malawi, we actually kind of a diagnostic through just quick questions about headaches and fevers, and was able to do presumptive treatment. Next slide. But that changed when we could no longer use those drugs, and the malaria protocol changed. So in Mali, for example, for a bit we actually were doing diagnostics and then treatment in Malawi because of change. But in Mali, instead of doing that, we ended up really increasing the use of the behavior change messaging about use of nets in school systems. And this is an example of kids doing some skits about when to use the mosquito nets. And this is where I will say it's interesting in Mali, because of the change in protocol, we had to change some research. And the research showed that doing education with the distribution of nets increases the use of nets. I give this an example because I just think, obviously, I think adding some education about use of nets would increase the use of nets, but we actually have a RCT that was done in Mali that proves that. But this is just an example of how we had to change our treatment of malaria in schools because of change in drug protocol, because of change in epidemiology of malaria and in the different countries. And again, it's school health and nutrition, but looking at the different roles and different pieces that we can do in schools. Next slide. Okay, next slide. And similarly with WASH, I think one of the biggest change and excitement about school health and nutrition and change is that 20 years ago, 30 years ago, schools often did not have drinking water and sanitation and hand washing, and school health and nutrition really worked hard in making that happen. And then 5 years ago, we actually came to some conclusions about what the definitions are. And we have this definition that goes across the UN agencies, and UNICEF and WHR are working with Ministry of Education and Ministry of Health to use these definitions so we can track and see what is the prevalence of good sanitation and hand washing. So I've seen the big changes, again, 20, 30 years ago, none of the ministries, not none of it, but there was advocacy necessary to include these items. And then more and more schools were taking this on, but now we actually have a global structure that is checking this and have come to agreement about the definitions. Next slide, please. And this is just more details about those definitions. And again, it is so amazing to have something as simple as clear definition, making a big change in how we work on things. Next slide. And just looking at the difference between a poor sanitation and not so good sanitation, and definitionally the one on the right will definitely be considered basic services, and the one on the left, you might say there is a latrine, but it does not qualify just because it's just not usable. And in the past, that one on the left may have been considered checked off because in theory there was a sanitation block. It just wasn't useful. But without that definition, it might have been considered as a infrastructure that's acceptable. Next. Similar, next one. So I did want to kind of focus on the operations and maintenance piece, and that's another lesson learned. I think there was a lot of frustration with school health and nutrition, and we talked about the need for infrastructure for many years and trying to get governments and donors to actually pay for that. But what happened is that often as we would go to schools and they would be old latrines or old water structures that were no longer working. And it's really hard to convince donors or anybody to reinvest when these things keep on breaking down. And one of the biggest change in Washington schools in school health and nutrition is actually looking at the operations and maintenance activities and working with the governments to see what's in the budget for these items. And if it's not in the budget, can we get the communities involved? And again, with the low resources, there's a lot of these pieces that we look towards the government as the structure that's supposed to do this, supposed to have budget for water and supplies and for latrines and so forth. But in reality, when you get down to the school level, there's barely enough money for the school teachers, let alone what they consider extras, like soap. We might not call it extra, but having a teacher is paramount before having soap. So recognizing the need for that, and then recognizing the low resources and seeing who can we tap into and have the resources kind of stretch further. So we do work with Ministry of Education, but we work with parents and teachers and students to see what they can contribute to these pieces of activities. And again, the cost effectiveness, it's not just the heavy infrastructure, but the operations and maintenance, and then having different partners involved. Next slide. And again, the nutrition education has changed over the years, looking at different needs at different contexts. This talks a little bit about that need for adaptation. And I think 20 years ago, there was some talk about physical activity, but it wasn't such a huge issue. But now that so many of the countries are dealing with double burden of poor nutrition and obesity, this has changed. So this talks a little bit about the adaptability of health and nutrition and looking at the different prevalence of different diseases. And obesity, again, has been something that 30 years ago we weren't talking about very much. We were talking about physical activities, but now I would say half of our programs are about that increase in active play. The world has changed, and then school health and nutrition program needs to change. Next. So, and if you have to push a whole bunch of them, yeah. So this is a slide just talks a little bit about the menstrual hygiene issue. And again, this is something we didn't talk about 20 years ago. And I bring this up in that we're working primarily in primary education where girls were younger and they hadn't hit adolescence and so we weren't talking about menstruation. But this is a critical piece as more and more girls are actually in school that we do need to talk about the needs of girls. And so this is just a slide that shows you how we can be very shy about talking about menstruation. And these are different words that people have used to describe menstruation, but we're trying to break that barrier. And so it's not, again, going back to the different roles and responsibilities, and it's menstruation is something you don't think about as a need for school health and nutrition, but when you look at girls need to be in school, feeling confident, having the resources to handle their menstruation, and understanding a number of girls who don't know what menstruation is before they start. And then when we do this, we do a lot of qualitative research, and it's amazing how many girls still don't know what's going on. The number of countries and communities that still have girls think they're ill because they're bleeding. It's in the 21st century, and this is still happening. But again, this is a piece of activity that we do need to consider in school health and nutrition as essential. Next. So just looking at the different pieces of what we can do with menstrual hygiene, not just providing services, but also doing the education and working on. It's interesting, the mental avoiding bullying. One of the key things we find is that there's a misunderstanding or lack of understanding, which leads to bullying and stigmatization of a very natural biological function. And that's one of the things we work on. It's not just to provide latrines and water and menstrual hygiene materials, but actually providing the education to the girls and boys, so we can avoid some of the bullying and misunderstanding. Next. This just goes through what's required for the 4 parts of school health when we're dealing with menstrual hygiene. Next. So we're gonna come to a conclusion. I was kind of racing through this because I feel like I'm speaking to a lot of people who know about these things, and I want to give people a chance. But I wanted to just kind of look at, again, the changing adaptation of school health and nutrition. And this is an example of the need to look at around schools, the road safety issue and the issue of air quality. Those are things that we have not worked on extensively, but again, looking at all the changes we have made and be able to move forward and looking at different issues that are coming up. Next. Okay, so that's it. I did race through it, and there's so much to talk about, and I just want to touch a little bit on the different roles and responsibility people have and the change in nature in the programs. Oh yeah, one of the things I did want to talk about is health education, and that's something that's really interesting. Is we know the health education is important, but the evidence piece of it is has been questionable, and we've actually started working with other behavior change pieces, such as putting nudges, reminders about washing hands. It's not just about health education, and there's a new desire to do better research on the cost effectiveness of health education. And I think the research goes hand in hand with the cost effectiveness piece. There's a lot we can do and a lot of things that are great for children's development in general. But I think when you're looking at lower resources, we're trying to figure out what does work better at lower cost. And I think health education and understanding what the right dosage of health education is a critical next step to understand what we can do for health outcomes. I will say some of the things we do may not have health outcomes. They may have other outcomes, and that's when some of the research findings can be mixed, in that when you are zeroing in on the health outcomes, some of the intervention seems costly. But when you actually look at the other outcomes of children's development, maybe parental development, teacher development, then the return on investment may actually be higher. So that's going to be an interesting question. Other question for me is scaling up. The deworming was an example of something we've been working on for 20 years, and it feels like all the pieces are in place. Governments have bought in to this importance of this. We have the right partners, but we're still struggling to get the coverage and the consistent delivery. So the question is, what's not working there? Okay, so I'm going to stop and turn it up back to Doug.
Okay, thanks, Sung. And I encourage you either to just click on your mic and say hello, introduce yourself, and ask your question or make your comment. Or I see that Doral has added one comment, and he's asking Sung if we can identify one key publication that documents the evidence for school health and nutrition programs in countries. There is that kind of research available, but Sung, if you wanted to recommend, or we can put it in the, can post it back into the webpage, the webinar's webpage, any key publications. There are a couple already, but we'd be happy to follow up on that. But Sung, is there one that stands out for you, or even open it up more generally to people online? Is there any key piece of evidence that that you think is really relevant today? I see Claire is typing a message as well. Sangha, maybe in
I'm
partial.
happy to talk.
Sure, go ahead. Yep.
Um, Obviously, I'm really interested in the questioning of health education, and it's. Oh, sorry, this is Claire Hanbury, Children for Health. It's something that I've heard really throughout my career, sort of 30 years or so. And I kind of wonder, and I'd be really interested if there is a sort of definition as to what is health education, because I'm sure everyone here is aware of there being, some health education is absolutely useless to do, very teacher directed and very sort of knowledge based and perhaps not the right developmental level. But that doesn't mean that health education per se is not useful. So I always wonder when I hear this, what the definition is of health education. And it would be, I love that sort of framing that you use, of, the dosage, the sort of, and I suppose also it's the kind of quality. So it's the amount of health education and the quality of the health education. And you mentioned a pillar of fresh is obviously participation, which is my particular interest. And it's sort of an analysis of sort of health education that's not working, which is using very participatory methods, but nevertheless is not working. Because I'd love to have a look at that and to kind of get a sense of where this sort of world of health education is with that. Sorry, it's a bit long.
No, that's Claire. I'm glad you brought that up, and I think that health education, like you said, the definition and what actually in it, it's really difficult. And I think the fresh webinars, we've had so many different implementers and partners describing what they do, and when it shows outcomes, the inputs are pretty extensive. And I think that is the question, like what is enough inputs? I remember 20 some years ago, there was J. Paul did a education RCT on HIV/AIDS education, and I would say that I was at the training, and I told them, like, we should really just stop this RCT right now, because what they're delivering is never going to work. And this is where when the intent to activities are measured on their intent as opposed to what is actually being done in some of the RCTs, and it just turns out like, again, that the results of the RCT clearly indicated that health education did not work, because they're like, well, this is in the curriculum, the teachers were paid to do this, the teachers were assigned to do this, therefore that's what we're measuring. And again, the definition of health education was what was on the curriculum, what was they were expected to do, versus what was actually delivered. And the RCT proved what I said at the very beginning. This is not going to work. So I think it's interesting what gets delivered and what is labeled as health education.
Yeah, I wonder whether there might be a really interesting resource that could be put together to almost like have to try and identify, what health education needs to be in order to be effective. I know that would be a pretty kind of skeletal thing, and obviously needed to be tied to the context. But so that these kinds of mistakes, which I've seen so many of, throughout my career, and then people turning around at the end and saying, you see, health education doesn't work. And like you, it's kind of the way in which it was delivered, all sorts of things, particularly materials and toolkits being delivered that teachers would never be able to kind of figure out and deliver given the context in which they're working, et cetera, et cetera.
Just a couple of things to pick up on that conversation. I think health education, it's one of the unique features of the FRESH framework is that there are 4 pillars, and we seem to have lost sight of how strong that pillar might be. In other words, we don't really have a clear idea how much is being delivered. In fact, we don't even have a clear idea of what is intended to be delivered in terms of what the curricula say and how many hours are intended, let alone delivered. And so one of the webinars in the series and one of the projects that FRESH is involved with, FRESH partners, UNICEF and UNESCO and others are working on just basically trying to get that basic fact finding together, and then to be able to look at the the intent of the curricula, let alone the delivery. And as part of that, Claire, through another one of these sessions, we have a working group trying to seek greater clarity and as to what is intended and what is feasible, what is truly feasible in a given context, and what is the minimum that we can seek to try to achieve. And that's going back a few years where we've lost sight of that kind of component. We've been always dealing with it in terms of issues, be it sex, drugs, or rock and roll, and we've never really looked at what is the kind of health education that needs to be delivered, and how much is it, and how much does it cost, and what are people actually doing, and so on. And so that's one of the things that the Fresh Working Group is working on, and one of the things that the UNICEF and other groups will be able to report on. But I think your point about the nature of it is even probably even more important, is what is the nature? Are we trying to engage young people to modify their environments? Are we trying to give them prescriptions for healthy behaviors? And that's another issue that needs to be explored. And that we've always put those aside because of the urgency of the day. And I think we really need to come back to that. And so that's kind of where I'm hoping some of these sessions, if you go back and look at those discussions and the documents, you'll see that we're struggling to get to there, but we're trying to maybe avoid some of those mistakes that some of us, including me for sure, that we've made in the past. Further comments or questions, just jump in, click on your mic and say hello, and ask your question or make your comment. I'm going to look again at some comments, and I think the behavior change, the nudge theory that Sung mentioned, that's been explored in terms of the relevance of school health and health education to behavior change, but it hasn't really been explored well in low resource countries. As you know, most research is done in high resource countries, but that needs to be explored more fully. And one of the things that in my Easter weekend, or actually in several of the webinars I've attended directly, is that because of the nature of the schools in low resource countries, we're struggling to put together school buildings and curricula, core curricula, often informal education, be it the extracurricular, co-curricular, school routines, and so on, is used as well, and perhaps better than in high resource countries, to enable young people to learn about these things. So one of the things that might appear in this future kind of agenda is what exactly can we achieve using informal educational opportunities, and can they be put together in a coherent way, not only to address one issue, but to look at overall health and development. And that's maybe another aspect that we might want to think about. Further comments or questions?
Just talking a little bit about the nudges, I just want to point out that it is a combination of some basic knowledge that children already have. So putting a hand print in near the hand washing station doesn't work unless they understand that they're supposed to wash their hands, right? And the nudges currently that's being used in some of the countries because of COVID-19 is when we do distributions. It's just like I guess in the US, in the shopping centers where they put the steps, lines to distance people. So similarly in some of our countries, we have put markers to social distance people. And I think that we may not think of that as a nudge, but although without those steps on the ground, people may forget and get close together. I think so. The small uses of nudges are showing up really interesting places. And we have done some study with the nudges where it showed that after certain basic knowledge about hand washing, additional education and messaging wasn't increasing behavior change. They all knew they were supposed to wash their hands, but they would forget. But the nudges really worked, and it worked even after the program ended, because there was, little footprints on the ground that kind of stay on. And the teachers were kind of tasked with having to repaint them if necessary. And I think that was it was an interesting dilemma that came up with like schools are like, we don't have pavement. So we're like, well, you don't have to use pavement. You can use a stone, and trying to get creative with that, and then like not having the budget for the paint. So sometimes when we talk about low resources, it does seem to be very basic. But the study did show that once those footprints were put on the ground, the children were reminded to wash their hands. So the behavior change we were looking for was sustained without people standing around reminding them to wash their hands.
Thanks, Sung. Just to move a little bit on, Irma has added a comment about health education and COVID, but I'd like to come back to that. Just to point people to the documents that are in the webinar description that we're looking for feedback on. There's a consensus statement that we're trying to develop about school health and development in low resource countries, and as well as a background paper. And the preparation time for the paper was supported by Plan International out of the UK and through their Young Health program from AstraZeneca. And we tried to identify some principles, and you can see with the big words in this text-heavy slide that in the draft paper you can see that there are 5 principles that we think are important. And then the second part of the statement is really trying to get greater attention on the part of policymakers, global organizations, and donors to really focus more on this low resource country focus. And the example, and I remember back in when we started this series, and I'd been following some of the Save the Children webinars, and so we Save the Children agreed to take it over and do it through the FRESH framework, that there is a need to articulate the needs of a given context, and many of you will know about the Education and Emergencies Network. It's about 50 different organizations, and they've been able to drive attention to that context of countries that are recovering from disasters or conflict or epidemics. And so that's what we think is important here, is we need to get more focus on the part of global organizations and donors and research agencies to really build up the knowledge and do the kind of things that Sung was sharing, doing that in a more structured way. And so here's are some of the things that are identified in that paper as a way of supporting giving more attention to this context. And so some of them are fairly understandable. Item 1, if in Sung's slide you saw a series of issues that may be confronting a particular country, but they need to be able to identify their priorities among those many issues, and to be able to select the aspects among those issues that are more important. And they need support to do that. That's part of a more of a strategic focus. So we're not just responding to some project money or some research money or a research project. We're actually working from the country's needs and priorities that they've set and that they own. And so that's the kind of articulation of these 9 points that in that draft paper, consensus statement, and then also in the draft paper. So if you take the time to follow up on the links, you'll very much appreciate the comments on that statement, and then also on the paper itself, which you need not spend a weekend listening to the recordings, although I would recommend it, particularly in these days of Netflix heavy consumption, to go and pick out the ones that you find to be particularly relevant. It really is that the 30 or 40 or 50 webinars are really rich in experience and evidence and really worth the time to they're not podcast formatted, but maybe we can figure out how to do that so you can listen in your car when we all go back to work. But it's those are the kinds of thoughts, and so maybe open up the discussion about are there general principles or are there actions that we can take collectively to encourage the powers that be to pay more attention to this context, and maybe open that up to anybody who would like to jump in and make suggestions and comments.
Doug, and I'm going to bring up, there was a comment about all the health education that's going on during COVID-19. So this might be an opportunity to highlight the school health importance of it. I will say, oddly enough, we just did a quick CAP survey of a program in Liberia, which in theory would have gotten quite a lot of health education during the Ebola crisis. But unfortunately, apparently that health education did not stick because we were still working with children who still didn't know about basic hand washing. I think the results are still being finalized, but my understanding is like only 20 to 30% of the school-age children knew about the importance of hand washing. And this is from a community or a country that went through Ebola crisis less than a decade ago. So some of these messages really don't seem to transfer down. And I'm kind of curious to see, as Professor Elaf mentioned during the COVID-19, all the health education that's happening, how much of that will stick and how much of the importance of doing basic school health and nutrition in general, how much of that will rise.
Others to comment on that. The bane of our existence sometimes, it's also an opportunity, is when a significant issue like COVID-19 appears, there's all sorts of attention that's brought back to public health, and then eventually some of it is focused on schools, and so that's a good thing. And knowing from experience in the SARS crisis, it hit Toronto quite hard, and there was a lot of investment in public health as a result of the SARS crisis, but it gradually waned. And so, how can we use crisis opportunities like this to actually build the infrastructure that we need for ongoing, and not to forget the lessons, as Sung has said. Is there any thoughts? Lloyd, I see you're online, and Margaret and others. How can we get away from this sort of respond to the issue of the day and then forget it kind of phenomena?
Doug, this is Lloyd. Can you hear me?
Yes.
Well, first I would say the presentations that Sung and you have done so far have just been superb. They've been very helpful. And to thank you both for your ongoing leadership for these many years. I listening to what was just presented, I think Sung's key elements of effective programming, for example, are so relevant to be applied to COVID-19 and everything that's happening. As Doug knows, there have been some informal discussions about school health with other agencies. And one of the focus of the discussions was the need to focus on low resource countries, as well as low resource schools within other countries. But how do we integrate what Sung and you have done as represented in just this brief summary today, and kind of carry that forward and integrate it with what is being done now on COVID-19? How do we, take those lessons and the experiences and the networks and thoroughly integrate it with all the things that need to be done? I guess is a question I would offer. I hope not rhetorically.
Thanks, Lloyd. Others to comment on that, on the cycle we go through so often, and maybe even to jump in a little bit more. And there's so much good work that's been done in school health and development programs, and we have these pillars or sometimes or components. The fresh framework has 4, some have 3, some have 5, some have 12. But we all sort of agree that the components are important, but then we often don't go back and and make sure that they're in good shape. Do we really do have a good health education program in our system? Do we really have a good set of school health and other services being delivered in or near schools? Are we really taking a good look at the social environment and what's available to schools as a minimum set of conditions? I've always gone to the issue of the day and pile on interventions on that issue, rather than looking at the infrastructure, the core pillars, as being a stable thing that we need to build, even though we also need to respond to the issues. You can't, if we ignore the issue of the day, there's not going to be much attention or funding or development. So how do we deal with this challenge, particularly in a low resource context? And so that's really important to try to deal with that challenge. And in the various webinars, there are answers in those presentations and discussions. One in particular, I think, because of this context, as I learned, there's 3 or 4 different webinars that looked at the notion that if you were going to start an issue, to work on an issue, and Sung mentioned this in her remarks, you really need to be careful not to develop a Cadillac when the country's driving Volkswagens, or in fact is riding bicycles. And so knowing what the ongoing and startup costs are going to be, and getting that well known before experiments are made with high cost items that are clearly not sustainable, as Sung was saying, with clearly not achievable in the context, a given context. And it might not also be resources, might be political or cultural or whatever, geographical. So what are the costs? And in the webinars, there are 3 webinars that actually have really good cost estimation tools that are useful to vision screening and to I think the other one was on deworming. And so that's a lesson learned, that we need to be able to do that. And I think this context has taught us how to do that more effectively than other contexts have. So again, opening it up for discussion to see if there's any other kinds of challenges that we've faced in school health and development that we, in this context, that we need to try to address as we move forward on this agenda.
Doug, unfortunately, it's time to go. So I wanted to thank everybody who actually made it to the this web meeting, and wishing everybody a healthy and safe sheltering at home or walking outside for a walk. And again, thanks for joining, and sorry for the technical issues. And as you know, Doug is happy to talk about this as much as you want. And if you want to join him in the watching of the webinars, please do. I think he just put where you can find them, right?
Yes. Yeah. Further comments or questions before we close? I see Paul is typing up a message. If not, we'll wait for that and then finish up. And Sung, again, thank you for this discussion. And we all didn't have to leave home, but we're all leaving our day-to-day lives to be able to be here virtually. Yeah, lots of thank yous from participants. And so thank you again. Encourage you to visit that page on low resource countries, or another page on the webinars. There is one tomorrow on dealing with another project of the Fresh Partners. It's looking at those cross-cutting themes that Sung mentioned in the beginning. There's been an expansion of those, and some of those issues that are being addressed in those cross-cutting themes are really about some of the generic issues that we identified here. How to implement, maintain, build up or scale up and sustain programs, and how to work through a systems approach. And we've been lucky to get 2 younger people, at least certainly than I, who have done research reviews on systems approaches, and looking forward to hearing from them, and then looking at that draft document which the Fresh Partners are working on. So again, thank you everybody for participating. I'm just going to shut off the tape